Medurstand. Understanding medicine.
Professor Aziz Rehman from Medurstand, and now I'm going to demonstrate the auscultation of the precordium, which is of course the most important and I must say most fascinating part of examination of cardiovascular system. And in fact, many students, many young doctors also, they sometimes straight away start with the auscultation because they know that the maximum findings are expected in auscultation. But I tell you, there is great importance of proceeding accordingly. I think if you examine pulse first, take blood pressure, examine neck veins, then come to the precordium, first do inspection, palpation, and maybe if possible percussion, and then do auscultation. Because this way, by the time you start your auscultation, you would be actually already anticipating certain physical finding, and it will be easier for you to pick them up and to interpret them properly. So before we start auscultating, let me define certain areas. Now these areas have got certain names according to certain valves, but they do not represent their anatomical location. For example, this area is mitral area, and this corresponds to apex beat, the fifth intercostal space just medial to the mid-clavicle line, and this does not represent the mitral area location. You know, of course, this is cardiac apex, mitral valve is somewhere here. But why do we call it mitral area? Because we know from our experience that any murmur arising from mitral valve is best heard on the mitral area. So that is why we call it mitral area. Similarly, this is the sternum, and the third intercostal space, third and fourth both I believe, fourth intercostal space just left to the sternum is called tricuspid area, because murmur arising from the tricuspid valve is heard best here. You go up, and this is the second intercostal space. Yes, this is second intercostal space. Area left to the sternum is pulmonary area, because right heart pumps into the pulmonary area, and murmur arising from pulmonary valve will be best heard here. Similarly, second intercostal space on the right side of the sternum is aortic area. Since we have another aortic area we call aortic 2, so this one would be called aortic 1, and this is aortic 2, which is third intercostal space right to the sternum. So when we auscultate, we must cover all these areas, but auscultation should not be restricted to these areas. You could adopt any sequence, but mostly we start from the mitral area, come this way, and so that's what I'm going to demonstrate. But of course, you will examine the whole precordium, auscultate the whole precordium, and if there is any abnormality, then you would extend your auscultation accordingly. Now let me demonstrate how to do that. This is the stethoscope. You should put it in your ears like this, and there are two parts. This is the diaphragm and this is the bell. For most of cardiac auscultation, we use the diaphragm. So diaphragm I'm going to use, I hold it like this. So as I said, I'm going to start from the mitral area. I will keep my stethoscope there for maybe 2-3 cardiac cycles. I just hear first and second sound, no third sound, no fourth sound, no murmur. Then I will proceed toward the tricuspid area. Again 2 or 3 cardiac cycle, upward, go to the pulmonary area, keep there for a few seconds, then come to the aortic area, then maybe if necessary other areas also. So this is the primary auscultation. If you just hear first sound and second sound, no third sound, no fourth sound, no abnormal murmurs, so this is, I think, pretty much okay. So you don't proceed further. But what abnormalities do you expect? First sound may be loud or may be faint. Second sound may be loud or faint. One of the components may be aortic component or pulmonary component. Accordingly, we develop the differential diagnosis. Third sound and fourth sound both may be audible, or one of them may be audible. That will lead to cardiac gallop. a sign of heart failure. So all these findings are expected, and I think it is important to know how the first sound is produced. First sound is produced by the closure of mitral and tricuspid valve together, and second sound is produced by the closure of aortic and pulmonary valve. But there is slight discrepancy. I mean, there is slight time frame. Aortic valve closes slightly earlier than pulmonary valve because of the greater pressure in the aortic root. So you could actually appreciate two different components of second sound, the aortic component and the pulmonary component. And there are some conditions, there could be some split of second sound, and that we will discuss in another video. So, and then we see if there is any murmur. What is a murmur? Murmur is a sound which is usually continuous, like shh, 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 like this. So murmur is a sound which may be systolic, or which may be diastolic, or may be continuous. So systolic murmur is the murmur which is between first sound and the second sound, and the diastolic murmur is the murmur which is between the second sound and the next first sound. So this is how you tell if it is systolic or diastolic. I think before that we need to know which is the first and which is the second. An experienced physician, an experienced cardiologist will have no difficulty at all, because first and second sound, they come actually in pairs. Bloop doop, loop doop, loop doop. The first sound has a little low pitch like a man's voice, and the second sound is slightly higher pitch like a woman's sound. And the distance between first sound and second sound representing systole is less as compared to the distance between second sound and the third sound. But if there is tachycardia, then this loop doop could become loop doop, loop doop, loop doop, loop doop, loop doop. So then it may be difficult. I think if there is tachycardia, then particularly you have to know the character. Another way is when you're auscultating, like for example, I'm auscultating like this, and if I put my thumb on the carotid pulse, which is just medial to the sternocleidomastoid muscle here, and the sound which corresponds with the carotid pulse, that is the first sound, and any other sound is the second sound. So this is how we auscultate. This is the primary auscultation, but let me add two things. For example, when you auscultated this mitral area, you heard a pan-systolic murmur, and you all know this pan-systolic murmur usually indicates mitral regurgitation, and one of the characteristic feature of murmur of mitral regurgitation is that it radiates to the axilla. So I would actually, after completing my auscultation here, I would go this way and this way, just to make sure if this murmur radiates to the axilla. So if that is the case, that would add to the findings of mitral regurgitation. And if I find a systolic ejection murmur here, then I would not complete my auscultation unless I proceed to the neck. So just to see if this murmur radiates to the neck, I will auscultate on both sides of neck like this, because murmur of aortic stenosis typically radiates to the neck. So this is the primary auscultation. You could just a normal person and few abnormalities. I think in the subsequent video I would describe some important features of some specific murmurs and what are the features you study whenever you find a murmur. Thank you.